Hello, everyone. Welcome to Everyday Infertility. This is your host, Savannah Keys. I am super excited about our guest today. We have Dr. Erin Wolff with Pelex.
Hi.
Yes, so today we're going to do a little bit of background on Erin and how she got into the medical industry and her background and history with infertility. We'll also talk a little bit about Pelex as a company today and how it's helping women in the infertility space, and then where the company is going in the future. I know that there's a lot planned that's super exciting. So, as far as a little bit of background in history on Dr. Erin Wolff, so she actually earned her medical degree from Washington University in St. Louis. After that, she completed her OBGYN residency at Yale and reproductive endocrinology and infertility fellowship at the National Institute of Health. As a leading reproductive physician scientist at a top goodness, academic institutions, Dr. Wolff actually sought to find answers for gaps in our understanding of reproduction. So, after finding Pelex, after experiencing the limitation of current fertility care firsthand and seeing the opportunity for disruption, Pelex is actually a reproductive health company leveraging telemedicine to improve access to reproductive disease prevention and treatment for patients throughout the United States. So I am super excited to be talking with Erin today. Erin, how are you?
I'm doing really well. Thanks for having me. I'm excited to be here.
Anytime.
Yeah.
I was joking with Erin before joining the podcast. We've talked on the phone a few times before this, and we both joined, and I was like, oh, we're matching, and we didn't even plan it.
Oh,
So, Erin, I went through your bio and I'm super excited to dig into, your history and background, but maybe a really good place to start would be, your history as a fertility doctor and maybe what made you want to start in the infertility space?
so in med school, well, I guess in reproduction in general, I was the oldest on both sides of very large families and have a ton of cousins. So my entire childhood, it was filled with exciting, pregnancy announcements and births, and it was always, the most exciting thing that was happening. So I've always loved like the excitement around pregnancy and birth, and then in med school I did an elective, and they were going to do their first gestational carrier cycle,
Oh, wow.
and it was back before people had done this a lot, and they didn't even really know whose name they were going to put on the birth certificate, who was going to pay for the labor and delivery bill. And it was just definitely a field where there was a lot of cutting edge technology that always made it to the clinic really quickly, and so I like that part of like that it was a field that was always constantly changing. I thought that was super exciting. So that's sort of what brought me to want to go into the fertility space at the beginning.
Yeah. And you worked at a fertility clinic for how long?
So I did fertility at Washington at Walter Reed Army Medical Facility,
Mhm.
and the National Naval Medical Center across the
Mhm.
street from NIH in training, and then an attending, and then I did fertility preservation at the National Institutes of Health. So started that program. So I saw a lot of fertility patients, and then also I worked for about a year and a half at a really large private fertility clinic in our area.
Very cool. It's one thing, and I obviously didn't go to med school, but in college, you go through your classes and you learn all of these, things and trades, and you go into the real world, and sometimes it's not exactly what you learned in school. Was there any difference in actually applying it and being in the actual day to day of those clinics?
Yes. So my husband and I actually experienced secondary infertility. So
Hmm.
even though I, um, was an IVF doctor and I worked at this clinic for almost 2 years, we tried to do IVF in that clinic. And it was really eye opening in terms of how it feels being on the patient side. And I
Yeah.
was able to text with my doctor because we trained together, we're close friends. And still, there were so many barriers for the process being really seamless in terms of communication, because it's a really unique situation in medicine where you can't you don't have the time to just say, well, the MRI will get back in 3 weeks and then we'll schedule an appointment and then we'll talk and then we'll make a decision and schedule surgery. Like, everything happens that day. So
Yeah.
you have to know how much medicine to take that night, and you have to get the labs back from that morning and the ultrasound results and someone to look at them. And so it's a very, very tight, condensed interaction with the medical system. And it was very eye-opening that it's like, someone, the ultrasound tech would tell me one thing, the doctor that saw me that morning would tell me another thing, my friend and doctor, we would text something else, but then they would have a conversation with the nurse coordinator some other time, and then she would tell me a fifth thing. And it was just like, oh my gosh, this is so stressful. And
Yeah.
I joke that even though my husband is an orthopedic surgeon, and I joke that he can, saw people's legs off, and he's fine with that. But he was very, very stressed out by the process, and which was a very surprising thing that I expected him to be able to really roll with the punches
Yeah.
of fertility treatment. But after later, I realized that we do have good data that 70 and 80% of not just women going through fertility, but also men have anxiety and depression, because it's not easy. on
It's not. No.
No, no,
So
yeah.
you worked in the IVF world and the infertility world, and then you experienced it yourself with secondary infertility. As someone has been going through infertility and IVF specifically, speaking with my doctors and my nurses, they see it day in and day out, but that's not something that they necessarily have experienced. And, they can tell you how much medicine to take and when to do it, but they oftentimes aren't sitting there stabbing themselves, feeling the burn going in. What was the experience of maybe talking your patients through that and then you're being a patient yourself?
So I would say that I have definitely had many times in my career where, once I experienced it personally, it definitely changed the way that I interact with patients. And like, over and over, whether it was when I was a new resident asking about breastfeeding, and I'm like, okay, don't tell me anything, I'm just going to ask it, but I don't really want to hear the answer because I know nothing about breastfeeding. And to miscarriages, and how, like, it always just occurred to me, I'm like, oh sure, it'll be fine, you'll just get pregnant again. And I said the most terrible things and had no idea how haunting and lingering some of those things
Yeah.
can be. And then, yeah, even, IVF, and how, wait, so, like, if I get canceled, I still paid for all my meds. Like, I don't know why that never occurred to me as a doctor, because I never
Yes.
handled that side of it. But I'm like, whoa, that's a lot of money that I'm just going to flush down the drain. Like, what do I do with that?
Yeah.
And then, yeah, complications. And when it does, things don't go smoothly, or you're trying to say, hey, look, I think there's a problem, like, and trying to interact with a system where things happen so quickly. It was definitely overwhelming.
Absolutely. I, have been with one clinic for a couple years and I'm switching over to another clinic, and I feel like I've experienced quite a bit of nurses and doctors with differing opinions, and one thing that you said kind of stuck out to me is like, oh, I never realized because I haven't been on that side, or and I think it's we all do it in our day jobs. We just get caught up in the normal day to day, and you have your process and you come in and you do what you need to do. And it must be a little bit refreshing being in the position that you're in with Pelex, having both sides to say, hey, from a doctor's point of view, here's what I'm suggesting you're doing. But I've also been there. I know, I get it. And I know for a lot of women and men in this journey, that's very comforting.
Yeah, I use it every day, honestly. And the nice thing about Pelex right now, that I'm just doing telemedicine, So up until, we're opening a clinic shortly and we can talk more about that in a little bit. I know we
Hmm.
have it on the agenda, but up until this point, I have been giving advice. And a lot of times the conversation comes down to the pros and cons of one treatment versus another.
Yep.
And I definitely have put more weight after my experience on the benefit of what I tell patients of getting a baby in your arm faster, like just like shortening that torture period, to just like, yes, maybe, we all hear stories of people that got pregnant after they did IVF, and most people are not infertile, they're subfertile. And if we were like my great grandma and had, exposure to pregnancy from when she was 16 to 46 and had 5 kids in 40 years or 30 years, then, all of us could have 5 kids in 30 years. But that's not really what our life, our reproductive journey and family plan, goal, family size looks like in today's
Yeah.
world. So really just shortening the time to pregnancy has its own value, and especially, but I like to meet patients where they are in terms of if they had their heart set on avoiding IVF, and as long as they know, like, yes, like, I understand IVF has like a much higher success rate, but I really wanted to work on trying to get the semen analysis better for my husband and me to be healthier. Like, can I try for a few more months? Like 100%. So I think it's really important to try and meet patients where they are, and listen to what their goals are and try and put that into the action plan.
Yeah. You mentioned, if everyone's journey looked the same as your grandma's. I don't think I've actually shared this on a podcast before, but my mom was adopted because my grandma couldn't have children. Well, back in the day, it was just that was your diagnosis. You can't have children, and there is no scientific or there is no medical opportunities back in that time frame. I mean, we're talking 50, 60 years ago. In your time of being a doctor in this time frame, what changes have you seen, or have you seen things drastically change in the few years that you've been doing this?
Definitely a lot of change. I would say the biggest change was when we figured out how to help treat male factor infertility with intracytoplasmic sperm injection.
Wow.
So when you, instead of just pouring the sperm and eggs in a dish and let the sperm swim and fertilize with
Hmm.
what we call conventional IVF, if certain forms of infertility, if the sperm don't swim very well, if they can't fertilize for whatever reason, we can take them up, suck one that looks healthy and normal, and poke it into the egg to do the fertilization. And that really, there was a big jump in our success rates at that point. Another big change was that we really started trying to only put back one embryo at a time to decrease multiples, because
Okay.
when IVF wasn't as successful, 30 years ago. So we would put back 2 or 3 embryos because a lot of times none of them would take.
Hmm.
But then we saw over time that the twins and triplet rates skyrocketed in our country. And then it became very obvious, like, those are not healthy pregnancies. And these couples that struggled and wanted these pregnancies so badly, then to have a really tough pregnancy journey, that it is really important to try and minimize the risk of multiples as much as possible. And then what has kind of gone back and forth like a pendulum in our field is testing embryos and trying to predict which one's the best one.
Hmm.
So when we first started doing it, we used to label the cells with like antibodies and colors, and like, yes, it's great. And then it's like, no, it has a lot of problems. The test like doesn't work a lot of times, so it doesn't
Hmm.
improve pregnancy rates. And then, well, now we have a new way of doing the test, and so now it's really great. But then now it's like, well, maybe we're accidentally throwing away some embryos that actually do have reproductive potential. And so, are we sure that this isn't doing more harm than good in certain patients? So, I think those are the biggest things in the short time that I've been in the field.
Yeah, that's so interesting. And the first one, I refer to it as ICSI, or at least that's what I've been told. And so when we first sat down with our clinic to do our egg retrieval, we know virtually nothing. I mean, I just remember every appointment, me and my husband would look at each other, deer in the headlights, and you're expected to make this huge decision, and you're spending so much money, and you're like, I don't know, what do you want to do? What do you do? And so you're you're kind of in this place where the nurse or the doctor explaining it to you, you're very heavily leaning on how they're explaining it and the benefits that they're telling you. And there is some bias to that. And so I know with the ICSI, our clinic, they were newer at the time, and they were like, hey, we are going to do this no matter what. Other clinics, it's optional. Okay, great. We're going to take what you say and run with it. I remember for the testing, it was, hey, this is your option. We're going to tell you what it is, but you have to make that decision. And I remember looking at my husband and him being like, I don't know. What do you think? And I was like, I don't know. Looking at the nurse, I'm like, well, what would you do? And so some of these things that you were saying are such huge advances in this, fertility cycles that people go through. I just wish there was more education on it, because we were expected to make a decision within a day or two. And it's like, we're asking our nurse, we're asking our doctor, we're going home and we're asking Google. Is that
Yeah,
correct? I don't know. You have to make the best decision that you can. So it's interesting to hear someone from the medical industry say that something like the testing swings so much. And that makes sense. The medical industry is advancing every day. And so I'm sure how they tested embryos today is very different even than how they did 2 years ago.
right. Yes,
Interesting.
I know. It's, and it's a field that changes a lot. So you can't even
Yeah.
rely on even a friend who did IVF 5 years ago. Like there's many new terms
Hmm.
and not to mention that like there could be different causes of infertility and you only understand your part. And we've only started talking about it more openly, honestly, in the last 5 years or so. I feel like it's a lot more open.
Oh,
So
absolutely. So you spent some time as a fertility and IVF doctor. What made you want to start Pelex?
So it was our experience with the secondary infertility, and then
Okay.
helping cousins and my brother and his husband and friends and our former nanny all go through IVF, and basically everyone had these like bumps in the road of their process. Or a lot of patients came to me, or actually more friends, say, "Oh, it's great that you're doing this. I wish we had you back when we walked in and we were the two people with deer in the headlights."
Hmm.
And so that's partly, I mean, the biggest part of what I wanted to do was to try and make it less painful, less difficult, make it easier, provide the same help I was for my friends and family. Because I figured that if I was kind of overwhelmed going through it as an IVF doctor and worked there, then other people might need this service as well.
Yeah, absolutely. I did an episode with my best friend, and we talked about the 1 in 4, the 1 in 8. A lot of people feel as if they're a statistic when going through any type of infertility. And so me and her were talking about her two best friends both went through IVF. And she was like, it's not 1 in 8. Is that even the most accurate statistic? And so it's interesting to hear you having so many people in what sounds like a close circle experience those similar, infertility journeys and need someone like that. And so I think that's great that you had the experience from being a fertility and IVF doctor. You also had the experience yourself, so you can help guide people and kind of back to what I said, be that person that knows how it feels and can provide that comfort. But then Pelex is born. What were the first few years, or what was the start of Pelex like for you?
So it's interesting. We were trying to provide services in more of a concierge medicine format.
Hmm.
And so over telemedicine, which was pre-pandemic when we started in 2017, so we couldn't bill insurance for office visits over telemedicine because it wasn't allowed. So it it was a little bit difficult. And it's also hard to try and educate patients that they're like, I don't even know what ICSI is, or sometimes, I forget and I use acronyms and I should not. And the husband will be like, wait, what's IUI? I'm like, okay, yeah, good question. Let me back up. But then to even have like that basic level of understanding, and then like, what do you mean sometimes cycles get canceled, or what do you mean, I can get a cyst, and it throws off our entire summer plans when I'm a teacher and I was supposed to do IVF this summer. It's just such a huge amount of information to process, and so then to try and explain what you're trying to do, that the patients, from the patient perspective, are like, well, why isn't my own doctor, I'm paying them a large amount of
Yeah.
money, why aren't they doing it? So it had a couple of problems. And then after the pandemic, the silver lining for Pelex was that we were already established as a telemedicine or telehealth company and provider. And now we were able to bill insurance, and it really helped us grow more quickly after that.
That's awesome. Telemedicine and everything is over the internet nowadays. And so it's almost as you guys were ahead of your time, which I'm sure makes it a lot easier. I know in our conversation a couple days ago, you had mentioned in the beginning, because you couldn't bill insurance, one of the struggles were that this was a cash service, and anyone going through any type of infertility treatments, they know it's not cheap. And so I I look at this as, I'm trying to start a family. I'm trying to have a baby. This is my only shot. And so, not that money isn't an object, but it's like I would do anything to have that shot at a baby. When people are coming to you in the beginning stages, the first couple years, how are they finding you, and what are some of the common cases that you're talking with people about?
Those first few years, it was more finding me by the reputation, and it tended
Good.
to be patients that have had really complicated, difficult journeys, and they'd had a few situations where they really wanted a second opinion about, do you think that that this was the best direction for us to go, or what would have been a different option for us, or can you look at my IVF cycle and tell me what you think, like if it went okay, or if that was the way that you would have managed my case. So it tended to be failure, like patients who've had multiple failures of IVF cycles at the beginning. Yeah,
Gotcha.
tough cases.
You, I think that's great. I've had two failed IVF cycles and then a third one canceled due to my thyroid. And really, after
Oh.
that amount of time frame for us, it was okay, this is kind of a natural, we need a second opinion. And that's scary for people. I mean, I had spent 18 months with this one clinic, and I felt like I was walking away from something of like, well, they already know me. They know how my body reacts. It took us X amount of cycles to realize that, like, I can't do birth control. It just throws everything off. And so I know how scary it is as a patient to get that second opinion, even though you want it so badly. So when people are coming to you, are they saying, okay, here's my history, here's labs, here's all of this stuff? What tools are you using to be able to give them that second opinion?
Um, one of the biggest things is to look at the IVF stimulation sheet. And I also
Okay.
do second opinions for a company called Second MD,
Okay.
and they gather a lot of the records, but almost never the sheet that I want, and the one that we always go to first, that has all the ultrasound measurements, all of the blood values by day, how much medicine in one spot. You almost never get that screenshot from the clinic, and so it's really difficult. So you're kind of like paging through, lots and lots of records to try and figure out what happened and piece together. And some medical records, it's a lot of copy and paste the stuff that's not important, and trying to figure out what the decision making process was in certain clinics for why they chose one thing or decided to go one direction. So it can be very difficult to piece it together. Sometimes patients have like collated all of their blood work, and that's always very helpful to be able to look all in one place and kind of have a summary. But that's basically, is like I'm trying to get the stim sheet and see how the estrogen went up, how the follicle sizes grew, what day the trigger shot was done on, how many eggs we thought we were going to get, and is that how many eggs we got, and what was the percentage that were mature, and what was the fertilization. And then you kind of try and read the tea leaves of what we think we might be able to do better the next time if we were to
Yeah.
do another cycle.
I'm just thinking back to my personal experience, and I don't know if I were to reach out to my original clinic and say, "Hey, do you have all of this for me?" that they would have that. I would assume most people probably have similar experiences. How often were you getting all of the data and all of the history that you needed?
It's never as good as if it's in your own chart and you know where to look, and because the way it prints out often isn't as good, or the embryology side to see how
Hmm.
the embryos grew and what their grades were sometimes doesn't come over with the records necessarily. Yeah, it's a difficult field of medicine. There's a lot
Yeah.
of data.
So in those first couple years when a lot of it is second opinions, how, and it's okay if you don't have an exact percentage, but if you had to guess, how many times was your second opinion different than the track that they were on or the journey that they had experienced with their current clinic?
That's a good question. I would say the majority of the time I agreed. And maybe it would just be like, oh, and I would just do like a one little tweak.
Mhm.
I would say very rarely I was like, oh my gosh, that was not good. We should, and then you have to try and figure out a nice way that's authentic to what your job is for the patient without trying to, badmouth your colleagues or something like that.
Absolutely.
But
Yeah,
yeah, I would say the majority
that's good.
was,
That's good.
yeah, yeah.
And I recently just got a second opinion, and I would say he probably was taking a similar route to what you just explained. At the end he was like, "Okay, do I think you're on the right track? Yes. Would I have changed anything major? No, I don't know. I wasn't in that situation. But looking at everything that we've talked about so far, here's a few things that if you were in my care, I would have changed." And sometimes, it actually, I don't know what I was looking for going into that second opinion because, as I mentioned, I had spent all of this time with my current clinic, and they knew my body and how it was going to react, and we had worked to that point. But at the same time, after two failures and a canceled cycle and all of these other issues, I kind of was looking for the change. And so I think that's great that you understand, like, you don't wanna go into that and just say, "Wow, everything's wrong, let's scrap it, let's start over." And so trying to find like, "Hey, this is great, let's maybe try this or tweak that." If that person takes your advice and there are some tweaks and changes, how were they going back to their doctor or clinic and sharing that with them?
Um, I would say there was a variety of situations. Sometimes it was, what do you think of my embryo testing results? And I could, give advice about, controversies in the field like mosaicism or
Mhm.
really unusual embryo testing results. Um, and also sometimes when you recommend something, it's also a normal thing that you do for your own patients, even if it's not a second opinion. So the first IVF cycle often is kind of our best guess in terms of how much medicine to use and what type of a protocol, and it's a little bit of an experiment and a treatment. And then we always review how it went the first time. And I would say it's more typical for IVF doctors to like to make at least a little tweak, because if it didn't work the first time, then we like to feel like we're doing something to try and improve chances. So that's pretty standard. I think you always want to look at the where the where we sometimes have to adjust medication because things are going too quickly or too fast or too slow. Then we know what the better dose is to start you on the first time. So those types of input about the next cycle to a second opinion is almost always part of the normal process in a clinic's own process. Um, and then I guess there's just been a couple times where I'm like, oh gosh, no, I wouldn't do that. Like, like I really think you need to go to IVF sooner. And it's helpful when I can say it when I'm not doing the IVF because I'm not getting paid by it. So I think
Hmm.
it gives patients a level of comfort that it's really there's a reason behind it that is really important, and it's not because it's helping my bottom line in some way.
Yeah, absolutely. So what's the current state? We've talked a little bit about, how Pelex was started and the first couple years. What does the current state today of Pelex look like?
So today I'm licensed in most states. We have a couple of providers that are also seeing patients on our platform, and we'll be going into brick and mortar, are opening our first clinic soon in Texas, where there have been some retirements and there's a lot of patients that really need care and not enough providers to help to give them the care that they need. So yes, we're really excited about opening our first brick and mortar clinic.
That's awesome. I think in our first conversation, you gave a stat of like, was it 40% of patients are 60 miles or further away from a fertility clinic? What was that stat?
Yes, that's exactly. Yeah, 40% of Americans are more than 60 miles from a nearest fertility clinic. So we are really trying to focus on areas where people have to drive many, many miles or states sometimes. So had a lot of patients that were in El Paso for a while, and they tended to get an Airbnb in Phoenix and stay there for 2 weeks to do IVF because there wasn't uh, enough spots to do IVF in El Paso. And I grew up in rural Ohio and definitely know there's baseline health and medical access challenges. And so trying to help patients in rural areas is also part of our that we're being very thoughtful about going into those areas and really trying to use as much technology as we can to make it less stressful and hard for patients to get the care they need.
Yeah. My work is extremely flexible. And my first clinic was 15 minutes from my house, 15 minutes from my work. So it was great. I mean, it truly was the ideal situation. Now, my current clinic is 90 miles away. And so that is something I'm very lucky that one, my company also has a office in that same town. And so if I do have to go up there, I can work from that office that day. Not a lot of people are as lucky, and I'm in a lot of Facebook support groups where I see people ask, how are you guys making this work? If you're hourly, are you taking time off? I've seen some people drive as far as like 2 to 4 hours in a given day. And I understand that it's not the norm to have a work that's flexible or have the PTO to do so. Or, maybe you have children or maybe you can't travel. And so I think the telemedicine piece is great. What made you start the brick and mortar? I mean, was it just purely opportunity or was that always the plans for Pelex?
Um, so the brick and mortar really was born out of the fact that I started seeing a lot of patients in Texas, and they just didn't have places to go. And while I was trying to develop the telemedicine piece and trying to grow that side of the practice, we really saw that there was such a need for just traditional, like basic fertility care in person. And we were lucky enough to partner with someone in that area and have a couple providers. And so then working together, I think it's going to be a really, really nice addition to be able to send my patients. Before I would have to figure out, okay, well, where are you? I'm not sure where that is in North Carolina. Let me try and think of, who I know in that area, and then try and call and get them in to see someone. But then I kept running into these wait lists after COVID, oh, it's 12 months in this area. It's 18 months in this area. It's
Yeah.
2 years in this area. And just realizing that there's a need for just more access to the most successful types of treatments, the IUIs and the IVF, and trying to help patients in that way and grow.
That's awesome. So currently, patients, or I guess when the brick and mortar is up and running, patients will still see you virtually, and then they will only travel and come in for things such as the IUI or the egg retrieval or the transfer, correct?
Right. Yes. And the testing and, the ultrasounds and the workup. But yeah, then hopefully they'll be able to do their intake appointment. And a lot of clinics are doing this anyway and had to because of COVID, doing
Hmm.
the history part of it over telemedicine. But yes, so now they can do monitoring, hopefully at outside satellite locations, and then
Hmm.
drive in just the one time for the egg retrieval and the embryo transfer.
That's awesome. One thing that we talked about, and I know it's probably a huge benefit to your remote and virtual patients, is Mira Fertility. And I know you're using that device to help track cycles. And I would love to hear you touch on that. One, I actually used Mira while we were trying to
Oh,
get pregnant, and I loved it. Prior, I was just using little cheapy sticks off
yeah.
Amazon, and I was like, I don't know. I mean, this is an eye test for, goodness sakes. Like, am I ovulating
Yes.
today? Am I ovulating tomorrow? Am I ovulating the next day? It was such a guessing game. And so I came across Mira, I purchased the device and I used it and I loved it. And I can at least sit down with my OB and I see a naturopath doctor for my thyroid, but I was sitting down with both of them and I'm like, I'm ovulating. Why am I not getting pregnant? Turns out my tubes were tied, but it was such a great device for me because there was no guesswork and it was super easy. I know that's something that you're using with your patients today. Can you touch on some of that data that you're using and how it's working for them?
Yeah, I love Mira, and I joke that I'm a recovering um, academic doctor. So, and I did a lot of research for many years, and I love a lot of data. And um, I think the most interesting part for Mira, for me as a IVF doctor, is getting so many more data points in the luteal phase, so the after ovulation to the time of your period, and to be able for me as a doctor to go in and see it from the patient or from the physician portal side, and
Mhm.
it automatically says, "Oh, their luteal phase is short." I'm like, "Oh, like it's so hard to under sometimes patients don't know that, or they don't know to count from when you have the little like high test to when their period starts, or that didn't ever flag for them, and it's really hard to get in a history sitting down and just talking. So there's definitely things that we can do to improve the luteal phase, and it's been really also interesting to see how much variation in some patients from month to month. Like, well, this patient seems to be like, 1 month is good, 1 month is bad, 1 month this was good, but this wasn't. Another month this was bad, but this wasn't. And then to try and be very intentional about how we're trying to correct the underlying endocrine problem. So, was it
Mhm.
because the LH surge didn't happen? Should we try to give that part back, or did their estrogen peak estrogen not get up high enough? And should we give medicine to help on that side, or did the progesterone not get high enough in the luteal phase? And it's really gratifying to be able to see when we do these interventions that the charts like look like they're supposed to look, and it's like, oh, that's why this works. That's why these therapies actually work. So
Yeah, and I don't know, is the physician portal, is that a newer piece of Mirror or have they always had that?
um I think it's more new, and um I think there's only just like a couple clinics that they've worked with. I think they've done some studies with a couple clinics, and then I think our clinic is one of the first ones that has rolled it out like largely for clinical use. And it's also a lot of time, I don't know if you've, a lot of patients sometimes have heard of a day 21 progesterone, and
Mhm.
there's a controversial part of our field about whether progesterone, luteal phase progesterone supplementation, ovulation induction cycles really works or not. And it's fascinating now because I can see every day, which we never get everyday luteal phase progesterone levels in the clinic, but on
Mhm.
Mirror I can. And sometimes the beginning of the curve is bad, or the end of the curve is bad, or it's too short, or it never got high enough, or you can see all different kinds of patterns. I think that we don't, I didn't realize before, essentially. So if
Yeah.
you're checking it just once on day 21, then you can miss some of these subtleties.
It's there are so many pieces when you're working through any part of the, fertility or infertility journey. I mean, you like clockwork are either doing at home testing or going into a clinic. And I've heard so many people like, oh, I missed it, or oh, I was a day late, or this happened over the weekend. And doctors' offices can't be open 24/7. And so when you were showing me some of those graphs and data points, I was just nerding out and I called my friends afterwards and I was like, guys, this is so cool. And they're like, that is really neat. And there were just a few examples that popped in my mind of prior to us going through, IVF. I was speaking with my OB and he was like, well, you can come in on certain days of your period and we can do testing and probably similar to what you're talking about because I did a couple rounds of Clomid, like let's make sure. And that's not always easy. Some of those days fell on the weekend. Some of those days, I'm like, I can't come in that day. And so I just thought that was so neat. And especially with Pelex being virtual and telemedicine, you could be working with someone in Colorado who's doing the daily testing and you're getting the data that you need. And you're saying, hey, let's go ahead and prescribe this medicine, or hey, do this or do that. I joke with my previous doctor. I was looking at so many tests and, counting so many days. Finally, me and my husband were just like, screw it. Let's just have sex every single day. And he was like, yeah, I see what you were doing there, but like, that's pretty taxing. And I'm like, uh huh, it is, especially for the amount of time we did it. But people just don't know. And so I think that's so great that you're using technology and data and still doing it virtually.
Yes, definitely. And it's interesting you brought up the burden of having timed intercourse, because with Pelex, with my telemedicine only portion, that was the only thing I did. I didn't do IUI, and I definitely underestimated the the impact that all of that timed intercourse can have on getting pregnant, and how
Mhm.
some couples have difficulty, or that timing it, and performance issues and stress, or work schedules, or
Oh, yeah.
a lot of different reasons why. Before, it never occurred to me. I'm like, I don't know, because we just did IUI. Like, I never had to ask about any of these things. But there's companies like Mosey Baby that you can do like home inseminations if it's becomes too taxing, or some men have hormone problems and it's difficult
Mhm.
for them to have intercourse or ejaculation. So yeah, I've definitely learned a lot more to appreciated how much like the timed
Oh, yeah.
intercourse can definitely play into it.
Yeah, me and my husband both work 8 to 5 basically, but we have friends who are police officers or work in hospitals. And it's things that, if that's not your experience or your journey, you don't think about. But, some people work 24-hour shifts or some people travel for work. And, all of those experiences, people have those. And so when you look at infertility as a whole, I sometimes just get caught up in my little box of like, well, this is my experience, and there's so much more to it. And so I think that's great. With the brick and mortar, is there a timeline for that?
Yes, we are planning to open March 1st.
Oh
So
gosh, that's
yes, I know, I
exciting.
know. We're really excited. Yeah,
That
yeah,
is
really
right
excited.
around the corner.
Yeah.
So, I'm sure you're excited. You mentioned that you're going to be partnering with some other doctors. How many on staff are going to be there?
I'll be coming in at the beginning, and then there'll be two other providers, and then also one nurse practitioner and then another one who's about to finish her nurse practitioner school. So there'll
That
be
is
up to five of
awesome.
us. Yeah, yeah, really,
That
really
is
great. Yeah,
really awesome.
yeah.
So you mentioned earlier, after COVID, we saw wait lists, and I know I saw them, up to a year plus. Is there a wait list for Pelex, or how do you all envision kind of helping keep that wait list down for people?
So there is a wait list in the city where we're opening, and
Mhm.
I'm going to try, and I've already started seeing some of these patients on telemedicine to get their workups complete so that they're ready for treatment as soon as we open our doors. And yeah, so just partnering. There's also a shortage of IVF doctors right now. A lot of clinics are trying to hire and can't. So for Pelex, I'm able to see patients remotely in a lot of different areas, or if we open other clinics, and then try and help get those wait lists down and utilize more nurse practitioners when we're able to, or physician assistants, and have everyone's practicing to the highest level of their licensure is a big push in medicine right now.
Wow, that's something I didn't know. But that makes sense. I mean, this is something that when you go into med school, you pick kind of where you want to specialize. And so, do you have any opinion on maybe why there is a shortage on IVF doctors?
Yeah, it's the number of training slots that are available. So our
Mm,
field only trains 30 IVF doctors a year. So it's really hard to get those positions because
wow.
there's not enough. So as IVF has become more, aware, people are aware of it. They are accepting it more. The demand, our population is rising. All of those reasons, there's more demand, and we haven't increased the number of IVF doctors that we're training.
Interesting. Very interesting. So, wow, you learn something new every day, and I don't know what my thoughts were, but in Oklahoma where I'm at, I think currently we only have, I think, 4 IVF clinics. And that's not a lot when you think about it. And I know other states like Texas have a few more, but still, it's never enough. And that's why we have wait lists. That's why, just to have one consultation, you may not even go at that clinic, it's months out. And so I don't know why I, kind of put two and two together, but that makes a lot of sense. What with your experience with Pelex, talk to me about some of the success stories that you've seen, or maybe some of your favorite stories that you've worked with over the time.
Yeah, my favorite stories are my telemedicine patients that I couldn't do IUI or IVF with. And so I had to kind of think outside the box in terms of really spending a lot of attention to detail about their hormonal status, getting their thyroid really optimal, treating prolactin issues, making their menstrual cycle like treating actual interventions that we see that there's a problem and want to focus our attention to correct. And I have been able to get patients pregnant that in my other settings in training in the military system, our military patients, and a private practice that we definitely would have just told to go to IUI or told to go to IVF, and I can't believe that I'm getting them pregnant. So even a couple of patients with premature ovarian insufficiency. So really, we think that their ovaries kind of stopped working and their hormone levels are like menopausal women.
Hmm.
And we know they can get pregnant sometimes, but with Mira, I've been able to see like, oh my gosh, their ovaries turned back on. Like, let's try and get you pregnant right now. They're working. And then let's make sure everything's timed up and teed up, and so that the timing of all the hormones are optimal. So yeah, a couple of them have gotten pregnant, which we would basically say, no, I'm sorry, you either have to do donor egg or you have to,
Oh,
I can't help you. And I didn't spend months trying to help them get pregnant. So sometimes it's patients that, for religious reasons can't accept IVF and this is their only option, and want to just give it a try without those types of option. So then it's like, okay, yeah, let's see what we can do. let's let's do this.
That's awesome. And, I'm a very competitive person, but I would think that would be a fun challenge for you of like, okay, someone's telling you you can't. Well, let's look at all of the data and let's make sure. We hear all the time that miracles happen or, someone has done X procedure, if they've tried this and then it finally happens or they switch doctors. And so I think that's super awesome. Um, Erin, if someone wants to come see you or meet with you at Pelex, what is the best way to get in touch with you?
So they can go to our website. It's Pelex, PELEXMED, pelexmed.com, and you can actually book with me directly on my calendar. And there's also a phone number on there that you can call and talk to us if you have questions about how it works. Um, and also email us at info@pelexmed.com.
Awesome. Is there anything, if someone's wanting to book with you in Pelex, is there anything that they should bring or be prepared to bring for that first meeting?
If they have had any prior testing, then it's
Okay.
helpful for me to see that. And yeah, we can make sure that we review anything they've done in the past. Or even if it's things like LH strips or monitoring their cycle, I'm happy to look at data like that as well. And there's a lot of great home direct to consumer testing like Modern Fertility or
Yeah.
Legacy or other home kits. And I think any testing that patients can get to decrease the amount of time to pregnancy is beneficial.
I think that is awesome. Is there anything else before we wrap up? I'm going to tell everyone and then we'll remind them where to find you all. But anything else you want to share or anything else that we maybe didn't touch on today?
Um, I guess the only other thing is that I think prevention of infertility is really underutilized. We have
Hmm.
preventative care for almost every other aspect of our life, but if unfortunately, if um, patients like us have made it to this podcast, then they probably had a fair amount of their own infertility. But if they can tell friends and family and teach other men and women that these conditions actually have an impact on your health. And if we
Yeah.
can correct it, sometimes the infertility is I like to call the canary in the coal mine. It's our first little hint that there might be something else of a chronic problem underneath, that if we try to treat it when patients are 30, then they're going to be much healthier by the time they're 60. And I always use the example that our pediatrician screened my 12-year-old for high cholesterol, which is basically to look for risk factors for a heart attack or stroke when she's in her 50s, 60s, and 70s. But we don't check,
Mm.
um, even if a patient comes into a gynecologist's office and says like, "Oh, I'm thinking, I haven't gotten pregnant. It's only been 6 months," and our guidelines from our societies tell them, "Oh, just go home and try. Come back at 12 months," which is like heartbreaking to me.
Yes.
So I think it's really important to be proactive, and we should be checking hormone levels in women every year at their annual exam, because it really does impact morbidity and mortality of women and men if they have fertility problems that's associated with those conditions. So it's better to try
Yeah.
and fix it early.
I think that's a really great point, and I was just having a conversation with someone yesterday, and they were like, "Oh, me and my husband are about to start trying." And, you know, being someone who's went through infertility and has done all the testing, that is something that I'm, like, shouting from the rooftops of like, "Hey, just check. Next time you're at your annual OB
Yes.
appointment, just like, hey, I know I wanna have kids,' or like, we're thinking about it, what can I do?" So you mentioned hormone testing. Is there
Yep.
anything else that you would just suggest for people to ask at for their next doctor's appointment?
Yes, because and I'm an OBGYN, so I'm gonna, criticize my own field, but it's so strange that we have patients that we don't check to see if they have recessive carrier conditions like cystic fibrosis or sickle cell disease until
Mhm.
after they show up for their 10-week new OB appointment. When
Mm.
Why didn't we check the genetic screening at the beginning, and then also the prenatal labs at the beginning, so that if you need a booster for against viruses that can cause birth defects in pregnancy, like then you can get it before you get pregnant, and you don't have that risk when you're pregnant. So I think we kind of put the horse or the cart after the horse a lot of times in our field, and it would be a lot better if everyone got a prenatal visit and some of this testing ahead of time.
That's awesome. I think that's super great. Okay. Alrighty.
Yeah.
Well, Erin, I appreciate it so much. As you mentioned, if anyone out there is interested in a second opinion or starting out in trying to, family plan or conceive, I think it would be great to set up time with Dr. Erin Wolff and her team. If you are deep into your infertility journey and you're looking for a fertility clinic. I think March 1st is an awesome timeline and it's right around the corner.
Yes.
So for those of you wanting to connect with Erin and her team on Instagram, it is at Pelex Med. So PELEXMED. And then Erin, you said the website's www.pelexmed.com
Yep.
or was it info@pelexmed.com
Yep.
for
That's right.
email? Okay,
Yep.
awesome.
Yeah.
So I'm super excited about what you're doing. I mean, from what you've said today, I think you're truly making a difference. And to me, I mean, the fact that you've been down this road, I think it lends a lot of credibility. I know if I were someone setting up time with you or working with you, there would be that comfort level because you've been there, you've experienced it. And while it's not something to brag about because it's not a great journey, I think it really will go a long way with you and your patients. So
Well,
I,
thank you so much for
yeah,
you doing this as well and getting this information out there and providing this awesome platform and for having me today. It was so fun talking with you.
yeah, absolutely. So I appreciate your time. I know we'll stay in touch.
Yeah.
And other than that, thank you everyone for listening. You can find us at Everyday Infertility on Instagram or email at everydayinfertility@gmail.com. And other than that, we'll see you all next time. Thanks, Erin.
Thanks.
Bye.